everybody, and a very warm welcome to another episode of Inspired Healthy Living with Purva. Did you know in Australia, 1.2 million people are estimated to have osteoporosis, and further 6.3 million are living with low bone density? Bone health is often ignored, which results in increased rates of falls and fractures, especially in the elderly population. To talk more about this topic, we have none other than Professor Belinda Beck with us today. I am honored to have her here on our show today. She is a professor in the School of Allied Health Sciences at Griffith University. She has taught musculoskeletal anatomy and conducted bone research for the past 17 years. Not just that, Professor Beck has published around 80 scientific papers and presented over 140 abstracts at conferences and symposia nationally and even internationally. She is on the advisory committee of all the bone related organizations you can think of in Australia and a few in America too. So, without further delay, I would like to welcome Professor Belinda Beck. Good morning, Professor Belinda. How are you?
Oh, good morning. I'm very well, thank you.
Great. Thank you so much for accepting our offer and a very warm welcome to this session. And I'm so excited to have you here today with us.
No, it's my pleasure, and I'm always willing to talk about bone.
I agree. I think we're always willing to talk about the subject that we're so passionate about. And you spent so many years researching about this. I'm sure it's very close to your heart, isn't it?
It is indeed, yep.
Great.
I
And
call it my expensive hobby.
I love that. That's really nice. That's a nice name for a research. Good. I think I can also think about it with my research then later. Expensive hobby. Good.
Hmm.
So, as a professor in bone health, what is the most rewarding thing for you about this, and why bone health? Why the love for bones? Where did it all start?
I think there's, I suppose the biggest thing is just making a difference. Making a difference in people's lives. And in my role, I wear two hats. So I'm a professor, which means I teach undergrad and graduate students. And the other is I'm a researcher. So the satisfaction, I'm sure you are familiar with this, the satisfaction that you get from helping a person learn something new is immense. And then when you see them go on to achieve great things and thinking that you might have helped them do that, that's just immensely satisfying. And so, but also in my research role, the satisfaction there is all to do with translating the results of the research projects that we've undertaken and the things that have been successful, and actually translating them into practice so you can change people's lives, because otherwise why are we doing it? Our exercise interventions for bone is targeted for people sort of towards the later years of their life, and they're the years where quality of life tends to deteriorate because you have more things wrong with you. And if you have a program that's able to influence that quality of life, and then you witness it, it's happening right before your eyes, it's immensely satisfying. So yeah, those two things, sort of helping people learn and changing
Mhm.
people's quality of life, incredibly rewarding, and I feel so lucky that I can do that.
I hear you. I totally agree with you. And I'm sure the work that you're doing is really helping so many people all across, which is commendable. That's great. So thank you for that first. Great. And would you like to tell us something about and shed some more light on the research that you have been doing? Like, what is it all about? And what do you think are your key findings about that?
Well, without giving you the full life and times of Belinda Beck, I can just give you I've always been fascinated by bone tissue and how it adapts to the mechanical the loads that are put on it. So, which happen when you exercise. And there's a real Goldilocks sort of effect happening with bone. So if you unload bone, so you send somebody into space, or somebody has a spinal cord injury, or they're even just putting a cast on somebody's arm, if you unload the bone, you take away the loads that it's normally exposed to, it will resorb and become much lighter and porous, and then of course weaker. Now, if you overload bone too much, a sudden overload is going to break it. If you're in that zone where you're training very hard in a sporting event, you can actually also overload bone by creating lots of micro cracks. So we want to load bone in the Goldilocks zone. So we want to make it as strong as it can be for your needs. You don't want it to be like a brick, because then it's really heavy. Bone has this wonderful adaptation that allows you to have a strong bone that's really quite light. It's phenomenal sort of material for that. But the trick is determining what is the best form of loading and amount of loading for each individual. So it's different in childhood and healthy adulthood and old age and unhealthy adulthood, and all sorts of things need to be taken into consideration. The one thing that we do know from my work is that you must overload bone a bit to make it adapt. You can't just keep going for a walk every day of your life and thinking that your bones are going to be growing more. They'll adapt to a point where they can withstand those loads and not get injured, and then they won't adapt anymore. So it's the same even if you're a marathon runner. If you run 10 miles a day for 10 years, your
Mm-hmm.
bones will adapt to be able to tolerate that, and then they won't get any stronger. So the concept behind our research program is creating an overload program that is safe, that won't cause fracture or injury, but will overload the bone sufficiently that it will actually be able to grow. And this is where we have this catch-22, because with people who already have osteoporosis, the trick is finding an overload that doesn't cause fractures. And this is what everyone's always been worried about in my field. For years, we thought that you couldn't overload people with osteoporosis because you would cause fractures. And the results of our recent trials have shown that that's not the case. You absolutely can. You just have to do it carefully, with supervision, with serious consideration for technique, and you get fantastic gains.
Wow,
And
that
not only do you
sounds.
get gains in bone,
Mhm.
but that you actually influence that other incredibly important feature of aging that causes us to fracture, which is falling. So as we get older, most people do less and less physical activity. Their muscles get weaker, and their balance gets worse. So you add
Balance.
weak muscles, poor balance, and weak bones, and you've got the perfect storm. People are more likely to fall over, and they're more likely to break when they do. So just focusing on making your bones stronger is not actually the answer. And this is, of course, the issue with taking medications for bone. They can be effective, they can increase bone mass. But if someone's still going to fall over, they're
What they
probably still going to fracture at some stage of their life. So, yeah, the prevention of falls is absolutely key, and that's why exercise is so powerful.
Absolutely, absolutely. And I think balance is one thing which is not being is the underdog kind of a thing. People are not realizing the importance of good balance, especially when they age. I mean, they feel it's
That's
okay,
true. And well, the most of us find that virtually any kind of exercise, getting yourself up and out of your chair and moving, is going to improve your balance to a degree. But if you want to improve it to an extent that it's actually going to stop you from falling, you have to do a very targeted, specific form of balance training, and you have to do quite a bit of it. So the recent meta-analysis in this area says that you really need to do it for about 2 hours every week, and it has to be high challenge balance training. It's not just, don't just stand on one leg and think that you're doing all you need to do. There's all sorts of little things that you need to do as well. So balance training it's definitely, as you say, it's a dark horse. People don't think about it very much, but it's vital.
It's really vital. I totally agree with you. Would you like to tell us something about Onero? Why is it unique, and what are the benefits for it for the clients with osteoporosis? And what is Onero
Yeah, so
for general people?
so
They would not
Onero
know. Yes.
Well, Onero is the name of our exercise program that we deliver through our translational research clinic, the Bone Clinic in Brisbane, and we've actually licensed that program so that other people can deliver it as well in the correct way and safely into this high-risk population. So you'll find physios and exercise physiologists around the country who also deliver Onero. Now, Onero is really the name that we gave to the exercise program that we trialled in our Lift More trials. So we ran a Lift More, LIFTMOR. I won't tell you what it stands for. It's one of these silly research acronyms, but it was useful for us, and it really does
Yes.
sort of it describes what we did. It's a heavy lifting and jumping program specifically for improving bone mass in people who have low bone mass, and we tested it in osteoporotic women. It was an 8-month intervention, and we found these fabulous improvements in bone. And improvements in function, people, the kinds of things that are markers of risks of falling, so standing up and getting and sitting down out of a chair and tandem walk, all those sorts of things. And it also improved the shape and size of the bones that are most at risk of fracture. So when you measure at the femoral neck, so this is the thigh bone, we found that the cortex of the bone was getting thicker. It wasn't necessarily becoming more dense, but it was becoming thicker, and the thicker it is, the stronger it is. So um, we also looked at the spine to see whether this heavy lifting was causing the fractures that everybody and many GPs are worried about this heavy lifting, and they want to protect their patients. But we showed that there was no evidence whatsoever that we were causing fractures, and we can show that from our very careful examination of the spines of all of the people in the study. Now, Liftmore M was the male version of the same trial, and we found virtually the same thing. And so Onero is really just the program that we called that exercise intervention we tested, and we've implemented it into the clinic. And now people come to the clinic, the bone clinic. They have the same kind of test that we did in Lift More. So they do all those. We have DEXA scans, so they look at their bone density. They have all those functional tests, including the sit to stand and tandem walk and functional reach and all those things.
Mm-hmm.
Opportunity to take up the Onero program twice a week and just 45 minutes, and we added in balance training for all those reasons I mentioned. And then at the end of 12 months, we test them again. So it's really a translational research clinic. It's a user pays, they come and pay for their training, but it is a research clinic through and through, and we examine whether they're improving, and 9 times out of 10, they do.
That is nice. That is so good to have an evidence-based, research-based thing actually in function. That is what you said in the beginning, that what is the use of this research if we cannot put it in practice? If we cannot
That's
change
right.
people's life, it is so huge. I know why you love your work
Yeah.
now.
That's right. Yeah, it's and every day. I mean, I was just at the clinic yesterday, and we did have to shut down for 4 months because of COVID, and it's been we really took a big hit, but it was worth reopening and having our COVID safe plan and having changing all our the way that we practice, because the smiles on the faces of these clients as they
Oh,
gallop up the stairs and come to training, and they're all ages from
wow.
late 30s right through to 90 years old, and they're all at various stages of um, fragility and strength and fitness and health, and they love it. They're dedicated. We were getting harassed by them so that to make us reopen.
I think that's the best thing to happen ever. So, what is, like
True.
you mentioned, with the age factor, like in the late 30s to late till 90s? What is the right age? When is it that a person, an individual, should start getting concerned about their bone health, or they should be taking? I agree, it should be forever. But what is the right? Like, what is the cutoff? Like, okay, now that's it. You should start taking care of your health. That's it, especially the bones.
Yeah, well, I hate I really don't like the answer I'm going to give you, because everybody who's listening will say, well, I'm, XYZ age, I can't go backwards. But the
Mhm.
reality is we have to start taking care of our bones from the minute that we're born. And so it's the parental responsibility to do that through childhood, and to instill this information so that people know that they need to do this throughout their life. And it's in childhood, you want to maximize what we call peak bone mass, because we get all the bone we're ever really going to have by the time we're about 20. And so there's this window of opportunity to maximize your genetic predisposition to grow bone to a certain size, because we're all different, and you'll have a different bone mass than me just because you have different parents. So, but we want you to get the most bone that you possibly can within those genetic parameters. And to do that, you need to do lots of running and jumping from the day that you're born. And you know that that running and jumping tends to drop off the minute you get sort of, you hit puberty, and it's not really that cool to do it
And it's mainly
anymore. And
this for boys
that
and for
that's
girls
right.
also.
And people tend to become much less active, and unfortunately they, particularly for girls, they tend to wean themselves off dairy and start drinking diet coke and those sorts of things. So they're taking out the other building block, which is calcium. And so when you get into adulthood, it's absolutely vital that now you've got your bone bank, your peak bone mass. By the time 20 through 30 is when for men it takes a little longer to consolidate that, but you don't want any withdrawals from the bank. You want to just keep all that bone. Now, if you get really sedentary, you're going to be losing bone basically from the time you're sort of mid-30s all throughout your life. The less active you are, because the bone says, well, you're not using me, so I may as well get rid of it. But if you stay active, you'll maintain. And you've got to do the same kind of exercise, that heavy, that loading your bones hard. It's walking is probably a lifetime of walking is going to help you maintain, but it's not going to be enough. You want to do a bit of lifting, a bit of unusual loading. Bone responds to different kind of loading. So a game of tennis, volleyball, if a bit of touch football, those sorts of things that a bone is not really used to. It goes, oh, well, I need to adapt to that, and I need to get stronger for that reason. So tennis is great because there's lots of side to side, and that actually is also helping you with balance and preventing falls. And so, it's another way to change it up a bit. And then, of course, when you get into old age, the idea in the old days is that people thought, well, you can't really grow much bone when you're older, so really all we're going to do is try and stop people from falling. So the emphasis is on resistance training and keeping people on their feet. Well, we've shown that that is categorically not the case, and people absolutely can grow bone. Particularly the people who have the lowest bone mass, they tend to respond the most. But uh, it it really does turn into a different sort of a scenario when you're older, and particularly if you have been sedentary throughout your life, or you're just genetically predisposed to very low bone mass. That's when you have to consider supervised, targeted training. You can't just go, oh, well, Belinda says to go and do heavy lifting and lots of jumping. I've got a T-score of -4, which means basically your spine's going to crumple just by sneezing. I'll go to the gym and do that. You're going to hurt yourself. So you must be careful, and you really need to do supervised training, and you need to be supervised by someone who knows what they're doing, who's been trained, to do this kind of loading. And exercise physiologists, I think, are the perfect clinician to do this, but also physios who are well trained in exercise training as well.
Great, great. Now that's really true. That's really true, Professor Beck. Now, I really found one of your studies very interesting, which is the bone health across lifespan, exercising our options. I love the topic also, the title of it also. Just want to learn a little bit more about it. Any unique findings from that? Any key findings that you would like to share about that study?
That was actually a review paper that we wrote many years ago, and so that was what I was just talking about then, about the recommendations for kids and then young adults and then older adults, is pretty much summed up in that review.
Okay.
But I did have cause to look at that paper, and it did make me smile how far we've come since the bad old days, where we just thought it was all about maximizing peak bone mass and staying as active as you could when you were a young adult. And that I absolutely was telling the company line at that stage was falls prevention in old age. And I would rewrite that paper very, very differently now, with a focus on, just definitely recommending people find a targeted program, which, as far as I'm aware, the only real effective one that has good evidence behind it is our Onero program, and that's the lifeline for older people with osteoporosis. So yeah, it was an interesting review paper, and we tried to keep it very. It was obviously evidence based, but I do think it's outdated now, and I would definitely update those guidelines. That was back in 2003 or something, so
Yes,
I've
yes,
cut
it was
myself a
over
break.
paper, but I really saw that coming up everywhere. So I was like, no, I think I have to
Mm,
ask about this. So, how
mm.
people can access the Onero program?
Obviously the Bone Clinic offers it. So if you live in Brisbane, that's easy. Come to the Bone Clinic. If we have a couple of different places where we train people. So in Bundaberg, we have a little training centre. On the Gold Coast, we're just about to start retraining. Opening our training centre there. It's at the Southport Bowls Club. We just rent some space there. Um, and we do have another site in Brisbane. But for the people who don't live in Brisbane or in southeast of Queensland, the best thing for them to do is to either go to our website and find the Onero an Onero licensee near them, or go to the Osteoporosis Australia website, and they've got a page dedicated to exercise. And we have a map of Australia on there with the locations of people who are licensed to deliver Onero. And so you can find a physiotherapist or an exercise physiologist who's trained to do this, and then you can go to them. Now, unfortunately, we don't have enough licensees yet to cater for all of Australia. It's a work in progress. If you can't find somebody who's close enough for you to get to, um, you've got a couple of options. You can go to an exercise physiologist and ask them to write you a program for bone, and they should be well enough educated that they can at least get you on the right track. If they're doing anything that's too high intensity and it's not supervised, I don't know that I would recommend that. The other thing that we offer, because many people, obviously, all around the world, actually, it's not just in Australia, we've got people contacting us from everywhere saying, can you please help me? So we did develop an online program. It's not our heavy lifting program because we know people will be doing this unsupervised. So this is more a falls prevention program. It's a 2-year progressive program. It's something like $5 a week, and it's just, they get exercises. We ask them to do a few little assessments at the start of the program, and each 3 months they do another assessment and they go up to the next level. And there's exercises in there, a bit of muscle loading, a little bit of bone loading through some stomping and jumping and things. There's balance and there's mobility. So all sorts of things to try to strengthen the system as much as you can unsupervised and prevent falls. And so that you can find that just by searching Onero online.
Wow, that's really nice. And I think having an online program is such a blessing for everybody all across. So I think that's great.
Mm.
That's really wonderful, Doc. So now there is slight confusion about arthritis and osteoporosis in a lot of
Mm.
in general people. So what is it? Would you want to just shed some light and clear this confusion here for us today?
Yeah, sure. And the oftentimes clinicians use the word osteo as a generic term, and of course, osteo is just the Latin word for bone. So everyone's got those. but osteoporosis is what the name suggests. It's really a condition of porous bones, more lower bone mass. So there's less bone in your skeleton, whereas osteoarthritis arthritis refers to the joint, and that's a completely different condition. That's when the cartilage in your joints degrades to the point where it's not providing the original amount of support and comfort in when your joints are moving, and so everything gets inflamed. So it's a joint condition. If you've got pain in your joints, it's much likely to be arthritis. Osteoporosis is frequently considered to be the silent disease or the invisible disease, because often you won't know that you have low bone mass until you get a fracture. And I suppose you can tell when people have the dowager's hump, the very curved spine at the top of their spine. That's called kyphosis, and both men and women can get that. That's when you have fractures in your spine. That would be due to osteoporosis, but that's really the only way you could see evidence of osteoporosis in a person. But that is in the bones, whereas arthritis in the joints.
In the joints, yes. Great. Thank you so
Mm.
much, Doc. Now, the other thing that I really wanted to know is about the risk factors. Both the modifiable, we've discussed some of them in our session before, but there are some modifiable risk factors and some which cannot be non-modified. So what are
Mm.
those risk factors for osteoporosis?
Well, yeah, so I suppose starting with the non-modifiable ones, the ones that you really can't do anything about, you're either male or female. Arguably there's that sort of that the genes and the hormones that go along with those conditions are what determine your bone mass to a very large extent. People say up to 80% of your bone mass is actually determined by your genes. Also, so if you're female, much greater risk. Um, the other one that, of course, is very, very strong risk factor is age. So the older you get, the more likely you are to suffer from osteoporosis, just because you've had a lifetime of bone loss if you haven't maintained it. Um, aside from that, sorry, go ahead. Did you have a question?
No, no, no.
Aside from that, most of the others are modifiable. So, um, obviously diet and exercise. Things like taking corticosteroids. So some people have inflammatory conditions where they have to take high doses of corticosteroids, and those drugs are just so bad for your bones. It is a recognized condition that you can create osteoporosis from being long-term on high doses of prednisone. So if you can possibly avoid it, you want to. There are some other drugs and other conditions that will contribute to osteoporosis. Probably not worth listing all of those there for fear of missing some out. Um, Off the top of my head, I can't really think of terribly many others. The main ones would be physical activity and diet, I believe.
So, I mean, that's what the main pillars of healthy life always come out. Whatever condition we talk about is your physical activity and your diet. And the third is your mental health,
Mm.
your stress, the way you manage everything. So, all these three things are like the pillars of life. And they're so often, taken for granted. Though there's such simple things
Mm.
and the basic things that we should be doing right for everything, but they're always taken for granted. Don't you feel that?
Yeah, absolutely. And actually, the three things I just remembered had,
Yes.
of course, smoking and alcohol are always bad guys. There's no real evidence that just a couple of drinks are going to cause too much, but alcoholics tend to have very bad bones. And with smoking, it's the likelihood that heavy smoking is bad for bones. Um, but the one thing that I didn't mention is vitamin D. Now, vitamin D is such an incredibly important hormone for all sorts of systems around the body, but particularly important for bone because it's required in order for us to absorb calcium from the gut. So we can eat all the calcium you want, but if you haven't got enough vitamin D, you won't absorb it. So and convert it, use it the way you need it. So when you talk about pillars, the oftentimes we talk about the lifestyle factors that are most important for bone health: exercise, calcium, and vitamin D. It's like the three-legged stool, and you take one away, and it's not going to stand up.
Exercise, vitamin D, and what was the third one?
And calcium.
And calcium. Yes, yes, definitely.
Hmm.
Definitely.
Yeah.
So
Yep.
that's like it's tool for bone health, definitely. Great.
Mm.
Um, so my next question is a very common question that I'm asked almost every day in my practice is the calcium supplements. Or what about, like, first we'll talk about only the calcium supplement, how much, when to take, which salt is better. So what do you have to suggest about that?
Well, it does depend a little bit on who you read. But I can tell you that there is a rather strident controversy about calcium supplements. I think the one thing that everybody agrees upon is that calcium should be taken through the diet if possible. And
Mm.
so that means finding high sources of calcium in your diet, which is largely dairy. And there are all sorts of things around people eating dairy, but for the most part, it's shown to be safe, and it certainly doesn't seem to have any association with breast cancer, which is what people are concerned about these days. And there doesn't even seem to be any link with weight gain with dairy. So we think it's pretty safe to recommend that people try and get their calcium through milk, yogurt, cheese, even ice cream, if if there aren't other sources, those kinds of things. But and only if they really can't or don't want to get it in their diet, then go for supplements. Now, there's some indication that there is a cardiovascular signal for people who supplement over 500 milligrams a day, meaning increased risk of heart attack, possibly even as high as 30% increased risk of a heart attack. And
30% with
yeah,
500 milligram. I didn't know
well,
that.
yeah, with greater than 500 milligram. Well, I mean, to me, it makes sense. And I'm not a dietitian, and I'm also not, a cardiac
Mhm.
surgeon. But it
Mhm.
seems to me if you're taking a bolus of calcium at any time of day, and your body isn't going to use that all up, it's floating around in your system. It's got to go somewhere, and where it ends up a lot of times is in plaques lining your arteries. Now, if it lines the coronary arteries, that's when obviously you're going to run into trouble, and that's the theory that that's what's happening. So that's a possible. As I say, it's a controversy. There are many people who don't believe that's a thing at all, and that they
Okay.
think that calcium supplements are completely safe. And the trouble is the research evidence isn't that great with large enough samples to be able to really decide. But I'm erring on the side of uh, but I don't think there's a huge risk. But if somebody has a history of cardiovascular disease in their family, then I would definitely be encouraging them to try and get their calcium through other sources. If they have to take a supplement, and really you need roughly 1,000 milligrams a day. You need a little bit more postmenopausally or the older you are. And if you're in a growing phase or you're pregnant or breastfeeding, but roughly 1,000 milligrams is an easy number to remember. My recommendation would be don't take it all at once. Break it up and have it throughout the day, and have it with food so that you don't get this big surge. So there are sensible ways to manage it. Uh, I took it for years because I personally am not a huge fan of milk, but but the research is convincing enough to me to probably scale back on a calcium supplement, and maybe just try to up my dietary sources.
Right. I mean, here I would just like to share an example, and it's a very strange and an interesting thing, new thing for me, at least, that what you've shared today here is, we've always thought and risked excessive calcium intake with the kidney stones also. So
That's
that is
right.
also one thing that we have been cautious with people. We tell them that, okay, please get it from your diet and don't get it like I see people who are taking calcium from years and years and years, and they don't stop at all, and they take
Mm,
1,000 milligram of calcium. That's what is
mm.
recommended. Like my mother-in-law herself, she has does osteoarthritis also. Calcium has a role in managing osteoarthritis also, or just osteoporosis?
Yeah, it's not my understanding that calcium has a role in managing osteoarthritis. Um, I would just yeah, I don't know for certain. That's not my area, but I've never
Mm-hmm.
heard that. I definitely think there is an increased risk of kidney stones if you're taking too much. And we have people coming to the clinic who, you think a little bit is good, then a lot must be great, right?
I
And
know.
so again, it's
Exactly.
definitely a case of Goldilocks with calcium supplements too. If you're getting 1,000 milligrams through your diet and then you're taking 1,000 milligram supplement, I mean, why? You
Why?
actually, um, I think you can't actually manage or absorb more than what is it, 2,500 milligrams a day, something like that. So you're right up there butting against that. Um, I I think it's highly unlikely that much over 1,000 milligrams is going to do you terribly much good. Although, as I say, the requirements for women over 50 of the recommendations are 1,300. Um, so I do think people need to be sensible about it, and there's no evidence whatsoever that superdosing yourself with calcium is going to help you beat osteoporosis. Just get enough, and focus on those other two legs of the three-legged stool, and you should be okay in the diet department.
Right. But someone with osteoporosis, and if their bone DEXA scan is low, the score is very low, then do you recommend that they should be on supplement for a while?
I don't think there's no evidence really to show that calcium by itself is going to is um, a powerful enough therapy to really get you out of trouble. It's an ancillary therapy. You need it to go alongside the other things that you do. So if you're growing bone through exercise, you need the building blocks, and so that's what you need to take. But if you take calcium by itself, there's very little evidence that it's an effective intervention for osteoporosis. You need to get enough, but taking more than that is unlikely to really help you.
I get it. That's great. That's a very important point, I think, here. And which salt? Malate, calcium citrate malate, or calcium carbonate? Which one?
Mm. Yeah, well, not being a dietitian, I haven't got all of the biochemical reasons at my fingertips, but when I was a postdoc, I remember being told that calcium citrate is the most absorbable form, and so if you were going to go out and buy some calcium, that's where you'd get the most bang for your buck. Calcium, but it's also more expensive, although I think that may have changed recently. But calcium carbonate is cheap as chips, but it's like taking a big chunk of chalk, and it's not as absorbable. So as I say, bang for your buck, you're better off with calcium citrate. But if you're really struggling to make ends meet, then calcium carbonate isn't a bad source. And maybe if you crunch it up and spread it out throughout the day so that you've got it throughout your diet, you might be better off. It's better than nothing.
It's better than nothing. True, true. Great. Thank you. Thank you so much for that. And which age do you think they should start these supplements? Is there any particular age, like when, or they should? I mean, see, nowadays, I think with all the MLM and all those marketing companies, all these supplement marketing companies in floating everywhere, I see people taking supplements just because they are selling those products to others.
Mm.
I mean, they
Yeah.
have heaps of things. So I feel that's so risky and so dangerous to their body. I don't know how much good are they doing to them. I feel they're not helping them at all. So
Mm.
when do you think that they should start, or what is their key point to start? Okay, now is the time for you to start with some supplements.
Well, I suppose, again, I should say I'm not a clinician. I don't see patients. I'm an exercise scientist. So the safe answer is to say when your doctor tells you you need it, or your dietitian, because your dietitian probably has a better idea of how much of establishing how much calcium you're taking and how much you need to take. So and if you're not able to get it through your diet, then perhaps the dietitian can tell you. So when it's determined that you're not taking enough, action needs to be taken. Now, my recommendation would not be to reach out for the supplement bottle. It would be to consult with your dietitian for other sources of calcium that you would comply with. So the answer to the question of when should you take supplements, I suppose, is whenever you need them. But if you're having a well-balanced diet with plenty of dairy, it's unlikely that you are going to need it throughout your life because you're probably getting an adequate amount. Now, there is a calcium calculator online. The IOF has a very easy calculator for people to put in the foods that they're eating, and it'll give you a rough value. So it's not a bad idea for people to evaluate what they're eating, and maybe first thing, look at other sources of food, whether you find calcium, and that information is very easy to get online too. And if you're really struggling, then maybe consult a dietitian and maybe consider a supplement.
Great, thank you. So, apart from the diet and apart from the known hormones that we know, like vitamin D and about the role of calcium in bone health, there are other hormones also that play a very vital role in managing your bone health. So, would you like to
Mm.
shed some light on that?
Well, I think we can safely say that the primary hormone that's important is estrogen. And we know that because of the effect of estrogen withdrawal at menopause. So the minute you take away estrogen, you actually take away the inhibition on one type of bone cells that stops that bone cell from resorbing bone as much. So it's why you lose a lot of bone at menopause. You take away estrogen out of the circulating estrogen, and then it's like taking the lid off the pot basically, and all the osteoclasts come out, attach themselves to
Mm,
bone, and start chewing away like crazy, and you lose bone mass. Now that's the reason why hormone therapy was so popular for so many years, and it was a very effective therapy for maintaining bone mass. But the Women's Health Initiative study in the US about 20 years ago found that there was also an increased risk of um, other side effects. And so that really put the wind up the clinical community and patients, and people went off hormone therapy in droves. Now, slowly, people are coming back to it because they realize that there is some benefit in it, and not all of the risks um, that were generically sort of applied from that study do apply to every form of hormone therapy. So for some people, estrogen therapy around the time of menopause, just
mhm,
directly after it, can be effective. It's not considered to be an effective therapy, 10 years down the track after menopause. Then there are other bone drugs that you would consider. But the answer to the question is estrogen is the most powerful bone hormone, and it's also it does play a role in for men as well, even though they have much less of it. So it's, as I say, it's the reason why we lose bone in spades when we
mm.
hit menopause.
Right, right. And thyroid and parathyroid hormone, what do you think about those?
Yeah, also important, particularly PTH.
Mm,
It's a very important hormone. Again, with the Goldilocks, the body is this system of balance, isn't it? So too much and too little is what you're trying to avoid with parathyroid hormone, and it is part of the system of regulation of calcium in the body. So it's important that we get that right. It has been developed into a drug, and in fact, it's uh, pretty much the only drug really that's been available for a while that acts on the other kind of bone cells, which are the bone forming cells. So I mentioned that estrogen inhibits osteoclasts. Most of the other bone drugs are also osteoclast inhibitors, so they prevent resorption of bone, or at least they reduce resorption of bone. So they're called anti-resorptive drugs, whereas
mm-hmm.
PTH is a bone forming drug. It acts on the osteoblasts and helps them to build bone. So that's, a very powerful drug, but it's not a first line drug. It's considered for people who have had failure on other forms of drugs or are at very high risk of fracture. It's quite expensive. It's taken from an injection because it's a peptide. If you take it through your stomach acid will break it all down. Whereas the others can be taken in pill form, although these days they tend to be injected too. So yeah, it's a whole other discussion, medications associated with bone.
True, true, true. And when we were talking about supplements, the cartilage building supplements these days, glucosamine and all those. So, what are your thoughts about that?
Yeah, well, so again, I should, with the caveat that I'm not a surgeon or an orthopod, and I don't do any work on joints. Um, Really, what I know is as a professor of anatomy, and so I teach a
Mm-hmm.
little bit about cartilage and so on. And I do keep an eye on that research, normally just through meta-analyses and things. Um, there has been massive controversy about chondroitin and glucosamine as to whether they're actually effective. If it doesn't work, they must have a massive placebo effect, because the meta-analyses suggest that the effect size is not that great, and so that they're not actually helping. But you speak to people who take them and they just absolutely swear by
Where
them,
by them?
including my brother-in-law, who just says, if I don't take them, I'm in pain and I can't walk. So, as I said, it's either an extremely strong placebo effect, or the studies are just not detecting what it
Hmm.
is that they're doing. So I can't tell you a definitive answer on that.
That's a
You'd have
very apt answer from a researcher. That's amazing. I love this answer.
to. Yeah.
Great, great, great. Perfect. Thank you so much, Beck. I mean, it was such a pleasure, Professor Beck, talking to you today. I mean, it was such an awesome, enlightening experience to know so much about bones that you're passionate about. Anything that you would like to say as an ending note to everybody so that they can take care of their health and their bones? Just one line or something that you would like to tell them, please.
I suppose the classic tenet is use it or lose it. It's a saying that really is made for bone and muscle. If you don't use it, you will lose it, and the end result of that is going to be fractures, whether it be because the bone is too weak or the muscles are too weak to keep you on your feet. You're going to fall. So use it or lose it. It's the answer to bone health.
That's a wonderful line. Use it or lose it. I love that. So, thank you so much. With that, I would like to thank Professor Beck once again for giving her time to us today. It was a pleasure having you over, and hope to see you very, very soon again. Thank you.
The pleasure was mine.